Welcome, Dawn Riders, Dawn Ride community. I'm very pleased to have with me here today Dr. Barb Vanderhyden. She's the Corinne Boyer Research Chair for Ovarian Cancer and involved in the as chair of the Research Committee for Ovarian Cancer Canada. She's here today to help us understand a bit more about ovarian cancer and some of what's going on with the ovarian cancer research landscape through the OVCAN initiative in particular. So welcome. In the last few decades, the medical and scientific communities have made such remarkable strides in preventing and treating other cancers, such as cervical cancer and breast cancer. Yet for ovarian cancer, when you look at sort of the picture over the past few years, it hasn't really changed that much. So why is this cancer different? What makes it such a challenge?
Great question, and one that we get often. There are some very unique features of ovarian cancer that make a particular challenge. First, its incidence is relatively low compared to breast cancer, for example, or even cervical cancer. So cancers that don't happen as frequently don't tend to draw as much research funding. So that has been a real challenge. But in the last 15 years or so, we've actually discovered that ovarian cancer is not a cancer. It is a whole family of cancers that tend to grow in the ovary. But we've recently discovered that not even all the cancers begin there. Some ovarian cancers that are classified as ovarian cancer begin life in the fallopian tube or even in another disorder called endometriosis. It's just that those cells love to grow in the ovary, and so hence they were always seen by the pathologist and by the surgeon in the ovary, and therefore called ovarian cancer. So knowing where the cancers begin helps to explain why they are also very different. Unfortunately, for decades, they've been treated all the same way. And so now we know that there's still a lot of work to do to try to determine what types of treatments are going to be best for each subtype of ovarian cancer. So the low frequency and the challenges in having multiple cancers be called ovarian cancer have been two of the primary challenges.
So as you've mentioned research, I think the average person out there knows that if we're going to make strides in beating cancers and progressing the scientific and medical knowledge necessary to do that, that we need to invest in research. But aren't other organizations like drug companies, universities, government agencies, aren't they making these investments? Why is it so important that charitable organizations and events like the Dawn Ride are so necessary to help with research?
Another great question. Universities invest in salaries for professors whose primary responsibilities are to teach and to do research, but they don't fund the research. The research funds that are obtained by universities, and particularly the scientists that work in those universities, is actually from mostly government agencies. In Canada, the Canadian Institutes of Health Research being the predominant one. Research generally has sort of three key phases. There's the basic or fundamental stage where a lot of discoveries are made, a lot of the investigations into the nitty-gritty of how, for example, cancers begin. That's where that work is done. If there's something that comes out of that could be used in a clinic, then there's a phase called translational, where all those discoveries are tested in human tissues or what are called preclinical models to try to see whether that would be maybe a good target for a drug to be able to stop tumor growth. The final phase is clinical trials, and that's where we develop a drug that can be tested in humans. Drug companies are not necessarily interested in the basic fundamental research where all the new discoveries are made. They're wanting to see good translational research already well developed before they will invest and advance into clinical trials, which is fair enough because clinical trials are very expensive, but they don't invest in the early stages. So the Canadian Institutes of Health Research are a primary source, but I can tell you that we're lucky if maybe 15% of applications are funded by the CIHR. So although it's a great opportunity for scientists to get money, the amount of funds available from the government is very limited. So you have 85% of those really great applications will not be funded simply because there are not enough government funds, not enough money from CIHR. So agencies like Ovarian Cancer Canada and the donors and sponsors that contribute to OCC are incredibly important. For example, one of the first things that OCC did when they had money that they could offer in terms of research grants was to offer pilot funding for investigators who had good ideas on prevention and early detection strategies. This is an area that is really hard to get funding for because it's a difficult area to study. And we put out a call across the country and said, if anyone has any good ideas or think they have some promising areas to investigate in the terms of prevention and early detection, bring it on. We'll fund as many as we can. And so that kind of money can be supported by Ovarian Cancer Canada and the funds raised by donors. It will never be supported by CIHR until you pretty well have proven that this has promise. So if we want to do the discovery level of research to get those ideas into practice, that's where OCC and the sponsors and donors are incredibly important.
So you've had quite a bit of success with the OVCAN initiative and some of that seed funding and some of the donors that you mentioned, but yet you mentioned that there's still a fair amount of good ideas sort of waiting in the wings. You can't fund everything you'd like to fund. So maybe you could share with us some of the really exciting projects that could really make a difference, some of the work that is just waiting for that donation and that money to become real.
How much time do you have? Because there are so many exciting things going on right now that in my career, this is the most exciting period of time. In part because of the OVCAN initiative and the opportunities that it's presenting. We just recently funded 4 clinical trials, all to investigate the best use of a new drug called PARP inhibitors. So PARP inhibitors can only be given to certain ovarian cancer patients depending on what defects are found in their tumors, BRCA1 or BRCA2 mutations primarily. But we are finding that women who don't have those mutations, some of them also will respond to PARP inhibitors. So the questions that are being answered by these clinical trials is, do PARP inhibitors work best alone? Do they work best in partnership with another drug? What happens in women where PARP inhibitors don't work? What's the next best option to advance their treatments? And so there's a lot of really great ideas bubbling out of these clinical trials. And within the next 2 to 3 years, we'll have a lot of answers on how to identify the women that are most likely to respond to PARP inhibitors. The next part of that is to make sure that every woman who might respond can be identified. And I can tell you that, for example, in Saskatchewan, they've recently contributed the province as a province money towards the OVCAN initiative, and one of their highest priorities is to set up the scheme to be able to identify BRCA mutation carriers in Saskatchewan so that those patients can then be given PARP inhibitors. Those inhibitors are turning out to be quite phenomenal in prolonging survival of women with ovarian cancer, and so it's really important that we identify the ones who are most likely to respond. So both of those aspects are really quite important.
So you mentioned earlier some things that are exciting in terms of early detection, prevention, and also mentioned how much less funding that such research might get from drug companies and whatnot. So what are the exciting things that are happening there? Because when we look at women's cancers in particular, those early detection and prevention have been absolute game changers. Cervical cancer, for example, the pap smear and now the HPV, we have a vaccination now. So is there anything exciting like that being researched for ovarian cancer?
Yeah, so there are 2 aspects to that. Prevention, yes, there's been a lot of work on prevention, and particularly coming out of British Columbia. They started many years ago making the observation that if many of the cancers are coming from the fallopian tube, why don't we just take the fallopian tube out for women who are having abdominal surgery and see whether that will reduce the risk of ovarian cancer. Most of the women can have their families before the age of 40, have their fallopian tubes removed, and that dramatically reduces the incidence of ovarian cancer. Ovarian Cancer Canada was actually in the process of doing a nationwide survey to identify how much uptake there is on that process across the country. BC has done it, and they actually advocate for any woman having abdominal surgery who is past their baby-making years, recommend that they remove the fallopian tube to reduce the risk of ovarian cancer.
Without changing the hormonal picture or anything. Yeah,
but that's not being done uniformly across the country, and it probably should be, and so Ovarian Cancer Canada is doing the survey to find out who's doing it, who's not, what are the barriers, and how can they advocate to overcome those barriers. So that's the major mechanism of prevention, or the most successful mechanism. It is still surgery. There's no doubt that it's not maybe ideal, and it's not a pill that people can pop in and reduce your risk. Although the oral contraceptive is a pill that women can pop, and that does reduce the risk of ovarian cancer quite substantially. After 5 years, so the risk was reduced by about half. It's probably the most effective strategy for reducing ovarian cancer, or any type of cancer, other than staying out of the sun and not smoking. And yet it's hard to advocate widespread use of the pill because there's also a low incidence of breast cancer increase. So we can't be advocating one without putting the other at risk. So it's really unfortunate, but that's so the surgery is right now the best preventive strategy. Same for breast cancer, is to remove the tissue that might be affected and hope for the best. So we need to make sure there's broad uptake of that. So that is one of the exciting areas in prevention. Early detection has been a challenge, and that's not for lack of effort. There have been 2 very large studies, one in the UK and one in the US. Hundreds of thousands of women each in these studies, where they followed them for years and years and years, and did everything that we thought would be important for early detection. Blood measurements of CA-125, ultrasounds, regular monitoring, and in the end, both studies came up with the same conclusion, is that they might be able to detect a few more cancers earlier than they had before, but there was no benefit to outcome. The women died of their disease as well. And part of that is we don't have necessarily the best treatments yet available. And so even if you detect it, you might not be able to treat it effectively. And so I think it's a combination of wanting to do both. Well, wanting to do all 3. Prevent it in the first place.
Yes.
If the prevention doesn't work, then try to find mechanisms to detect it early. And if that doesn't work, be ready with a whole variety of treatments that are likely to be effective and ideally personalized, so that the woman with a BRCA1 or a BRCA2 mutation will immediately be put on a PARP inhibitor, or those who have other markers that we now are seeing are coming out of the different subtypes will have a treatment that's likely to work more for that woman than maybe some others. The rare subtypes like low-grade serous cancer, endometrioid ovarian cancer, these don't get as much attention because there's even fewer of those proportionally than the high-grade serous. And so we're putting a lot of effort right now in making sure that women with the even more rare versions of ovarian cancer are being considered in the research program.
It certainly sounds, though, like that basic fundamental science research you're talking about is the key, because if we can't detect it early using the tests we already know about, then the only really real hope is those new tests that have yet to be discovered.
Yes.
A question for you then. Our Dawn Ride is a motorcycle event, and in Canada, approximately 80% of motorcyclists are men. So how do we take those men and actually demonstrate to them, or give them some reason to care about ovarian cancer, quite frankly? If they haven't been touched by the disease, how do we appeal to them?
I am sure most of the men who ride motorcycles have women in their lives. And every woman who has ovaries is at risk of ovarian cancer. I spent much of my youth on a motorcycle, and I would love to come back to that. But I think it's important for both men and women to realize that the risk, yes, is in the woman, but it affects strongly the welfare of the men who love them. We have found this over and over again, that when women are unable to maintain a good quality of life, that the families around them are strongly affected. As you'd expect, mothers are often the center of the home, and so you do want to ensure that they remain as healthy as possible for as long as possible. There's also lots of commonality, not only between ovarian and breast cancer, but between ovarian and prostate cancer.
Really?
Yeah, so these are all what are called hormone responsive tissues, right? The prostate responds to androgens, testosterone. Ovaries and the breast tissue respond to estrogens. And so many of the mechanisms by which they become cancer are actually quite similar. There's more variety, let's say, in the ovary because of the different subtypes, but some of the elemental stages in early development are very much the same. So what we learn in ovarian cancer, we can look over the fence and see, does that work for prostate cancer as well? Is there something there that might benefit them? And vice versa. We are constantly looking over the fence at breast cancer and prostate cancer and even colon cancer to see, is there anything that they are learning that could apply to us?
Estrogen and testosterone, not as different as we might have thought. There you go. Is there anything else that you'd like to add now that you have an opportunity? Anything that we haven't covered?
We've talked a lot about the basic translational and clinical research and OVCAN and the science. I think it is important to note that Ovarian Cancer Canada has a broad spectrum of research that includes engaging patients. I think it's most important that we learn what the patients are going through, that we understand their experiences, and that they tell us what the big problems are. And so Ovarian Cancer Canada is doing what they call the Every Woman Study, which reaches out to women with ovarian cancer to learn from them what have their challenges been in being diagnosed or treated, or having follow-up or having support, so that we can do the research that's necessary to make sure that process is as efficient and supportive as possible, right from the moment of diagnosis and even beforehand, right through till the final treatments.
On behalf of the Dawn Ride, thank you so much, Dr. Vanderhyden, for joining us today, and it's been a fascinating conversation. And thank you as well on behalf of our ovarian cancer patients for all the really important work that you do.
It's my pleasure. And I look forward to getting on a motorcycle and being with the Dawn Ride one of these days.
I think the Dawn Ride needs an honorary Dawn Rider.